I'm Angela Wowczuk. I'm in presentation mode as I introduce myself. Um, I am a service assistant professor with WVU, and I'm also director of Rational Drug Therapy Program. There we go. Let me flip this around. And so today we're going to talk about long-acting injectable medications. My colleague Nick Kotov helped me put these slides together and did a lot of research behind some of these things. And my student, Allie Raggle, she's a fourth-year pharmacy student, helped me research some of the Medicare questions you all had. And I'll save that stuff to the end because I'll be honest, I don't have a whole lot of great info that we found for that because it's just a toughie affording these medications for Medicare coverage. But we will get to that and start out with a little bit of an overview. So we're going to talk about benefits of long-acting injectables, barriers to using these types of medication, and cover some clinical pearls and dosing nuances for these medications. So we'll start you out with some stats. So as we wade into the discussions, an estimated of 2.8% of US adults had bipolar disorder in the past year, and about 3.7 million had schizophrenia spectrum disorders, and these are patients ages 18 to 65. Adherence really widely varies, as I'm sure it probably does for most things. But it winds up right about 50%, with some studies showing 4% and some 72% of non-adherence. So can vary pretty widely depending upon several factors that we'll talk about in just a moment. And since adherence is so important, it's important to talk about the benefits and barriers of these types of medications. So we're first going to talk about barriers to adherence. And we'll start off with lack of insight or rejection of treatment. So many patients with mental health disorders might not believe that they actually have an illness, or they might not understand their diagnosis. So they might be resistant to pursuing treatment. Some people who suffer from mental health disorders also can have hallucinations or delusions, even when they're on medications, that can convince them to stop their medication. We'll go down to the bottom of the slide, side effects. So these medications are like most medications, and they have side effects that are associated with them. They can cause neurologic changes, they can cause metabolic changes, and potential long-term mood disorders. So though they are pretty well tolerated, there are things to consider. High cost is always a problem with newer medications, and long-acting injectable antipsychotics does not escape that problematic factor. So high cost can be different or difficult for patients, especially when patients may be switching jobs a lot or having a lot of insurance changes. So it can present a really big challenge. And then furthering that challenge, access in a rural state can be a problem. So there might be pharmacy deserts or areas where these medications are only available in specialized facilities. Drug and alcohol use concurrently with some of these diagnoses can be a factor in non-adherence, and that's not exclusive to mental health disorders. That can be across the board. Lots of studies show that if you have the drug and alcohol issue, it can affect adherence for any medication. And on this slide that I previously showed, the statistic that showed the 72%, that was in a study with patients with previous drug and alcohol abuse issues. So we've got lots of studies showing that that can negatively impact adherence. So when patients don't stay on their medications, particularly for mental health diagnoses, the consequences can potentially be severe. So we can have hospitalizations, higher risk of suicide, delays in recovery. They can have issues with the law and have arrests or regress on substance use disorders. There can be psychiatric emergencies and just overall poor quality of life. So it's important to help these patients in the best way that we can. Risk of relapse is particularly concerning for patients with schizophrenia or schizoaffective disorders. The likelihood of relapse, it can increase dramatically over time, with almost a five-fold within 5 years rates of 81.9% was a statistic that we had found. So it's a very, very big concern. Beyond the human toll in these patients as individuals, The financial impact can be large as well. So in the United States, over $10 billion can be attributed to schizophrenia-related costs in the United States. Now, taking that statistic in the study that I read, there's about a 40% of those costs are directly attributed to non-adherence. So long-acting injectables, you can kind of see what I'm foreshadowing here, greatly help with adherence, and it can help with some of these issues that we see with these patients and hopefully have them live a better life. So when we think about people who might benefit from long-acting injectable antipsychotic medications, there's a few key groups to keep in mind. So touching on the benefit of improved adherence, there are patients who can stop taking the oral medication and quickly become symptomatic again. And again, some of those consequences that we went over in the previous slide, having issues with the law, there can be assault, self-harm, losing their job or maybe their housing. These can cause bigger effects down the stream. So we want to make sure that we can help them at that basal level of adherence with their medication. So it helps their overall mental health. In addition to that, atypical antipsychotics that are long-acting injectables improve adherence, and studies have shown that. They help reduce relapse risks. They can also be an early sign that somebody is a non-adherent patient, because it's a lot easier to catch that somebody didn't show up for their injection at the office than when they miss a few pills here and there and they're just, getting their auto refill, and so they appear to be a compliant patient. Another group is patients with schizophrenia who might have treatment-resistant illness. So you can identify patients that maybe aren't having issues because they're non-adherent, and putting them on a long-acting injectable if they're still having issues with medication. Maybe the medication itself just isn't the right medication for the patient, or maybe they had inadequate blood levels from oral dosing. So it can help you get to the bottom of some pretty treatment-resistant patients who are still having issues on oral medications. Because these medications do offer smoother pharmacokinetic profiles, so you have less peaks and troughs. And like we had mentioned, the side effect profile of these medications is not insignificant. You can have sexual dysfunction or movement disorder, and avoiding higher daily peaks can drive some of those side effects and help the fact that those occur. So that would be a benefit as well. Also, you have consideration of patients who might have absorption issues. So patients who might have had bypass surgery or any other condition that makes oral absorption a little bit unreliable. These options can provide a consistent drug delivery regardless of their gut absorption. And finally, we want to look at our caregivers and our patients. It might be their patient preference or their caregiver preference to, not worry about if the medication was taken on a daily basis, and that long-acting injectable option can be a pretty welcome option. So here's a list of the medications we're going to talk more in depth about today. So we have our first generation atypical antipsychotics, and then our second generation. They're all essentially modified versions of their oral formulation that we're probably already pretty familiar with. The form of, The form of pharmacologic delivery of the long-acting injectable determines the immediacy of the release. So some options are every 2 weeks, some are every month. We have one that's every 6 months. So it offers the patients quite a bit of freedom in their dosing, and it offers the clinicians opportunity to determine what they're comfortable with, if they would prefer something that has a shorter duration but still offers the benefit of the less frequent administration, not daily administration, but it lets them check in with the patient and tweak dosages a little more commonly. So we have some options that we'll talk about. When it comes to choosing the options, there can be a lot of things to select from. Particularly, paliperidone has, lots of options for treatment durations. But to simplify it, we just want to make sure that we get the right patient with the right med at the right frequency. So it's depending a lot upon, their ability to tolerate medications, and their potential side effect profiles. And of course, we can't forget about cost. Cost and insurance coverage is a huge deal, because if the patient can't afford it, they're not going to consistently get it. So that has to play into decision making quite a bit. So first touching on the first generations, Haldol and flufenazine. They're both FDA approved for treatment of schizophrenia. They have a black box warning, as do all antipsychotics, about mortality in the elderly for patients with dementia-related psychosis. So something to bear in mind there. And we want to keep in mind some key precautions. So things like central nervous system depression and increased fall risk can be associated with these medications. In terms of side effects, the big ones that we focus on with this class is the extrapyramidal side effects, the metabolic side effects, and QT prolongation. I won't go too in the woods with mechanism of action, but I've listed it on these. Injection, the ester will slowly separate from the oil, so it allows a gradual release over time. So again, lending back to that consistent blood levels, less peaks and troughs, to hopefully give the patient fewer side effects with a better outcome. So reaching a little bit further into Haldol. So Haldol is given intermuscularly, either in the deltoid or the gluteal muscle. Single doses of about 10 to 15 times the patient's daily oral dose. If that dose comes out to more than 100 milligrams, we have to split it. So the first injection is capped at 100 milligrams. The rest is given 3 to 7 days later. And for starting doses, if it's higher than 400 milligrams or more, it really has to be split into 3 injections, again, spaced out 3 to 7 days apart. Max initial dosage is going to be capped at 450 milligrams. Sorry about that. It does take time for this medication to reach steady state. So some clinicians like to do an oral overlap. So if you take that approach, there is guidance on that. The oral medication would be gradually tapered over a month, beginning 1 to 2 months after the first injection. So you do want to have a pretty big overlap with this type of medication. Typically for tapering, the practice is to reduce the dose by 25% at weekly intervals. But again, the good thing is we have guidance on that with the package labeling. So that is there and helps us when we determine dosing. Some patients do require faster or slower. We know that every patient reacts differently to every medication. So these medications are no different from that. Tolerability and efficacy definitely tailor treatment options for all of these medications that we'll talk about. For maintenance dosing, you're going to adjust the dose based on response and tolerability. Usual dosages, you're going to be right around 10 to 15 times the previous daily oral dose. Skipping over to flufenazine. So this injection is, again, same as the other, given intermuscularly, either in the deltoid or the gluteal muscle. When converting from the oral tablet to the long-acting injectable, rule of thumb is 1 milligram of the oral equals 1.25 milligrams of the injectable, given every 3 weeks. And for this one as well, because it takes the body some time to build up to effective levels, usually they stay on their oral medication, and we have a good bit of overlap. For this one, at least the first week after starting the long-acting injectable, so not quite as much as the Haldol, but it does have overlap. So moving on to the second generation long-actings, they're all FDA approved for schizophrenia. And then we do have some that are approved for bipolar disorder. So the injectable forms of risperidone and aripiprazole also carry the approval for treatment of bipolar. As with all antipsychotics, we have that same black box warning. For precautions for these, we want to watch out for increased CNS depression and increased fall risk. We want to pay attention to extrapyramidal side effects, metabolic syndrome, and QT prolongation. Particularly for all these side effects, but particularly metabolic syndrome, some are worse than others, and we'll talk about that as well. First, we'll discuss paliperidone. And we have several options with several options for intervals. So we have some 4-week options, some every 12-week option, and then every 6-month option, which sounds really great to only have to take your medicine twice a year. So the Azofree is given every 4 weeks, as is the Sustenna. The Trinza stretches the interval to every 12 weeks, and the Half-Yera, I like that name, very clever, you give it every half year. So you give it every 6 months. These are given intramuscularly in the deltoid or gluteal muscle as well, but depending upon the product. So the Azofri, Sustenna, and Trinza are given in the deltoid. The Half-Yera has got to go in the gluteal muscle. We all probably already know this, but paliperidone is the active metabolite of risperidone. Mechanism of action is there for your viewing. There are a few clinical pearls that I'll discuss because they stick out. This one is renally excreted. So if you have a patient with existing renal impairment, you need to either avoid this medication or dose adjust. Each formulation has specific protocols if a dose is missed or given incorrectly, but those protocols exist and are available for guidance. So again, that's a good thing that these medications have been used for a good bit. Another practical point with this one that is a little bit of an ease with storage is that they are all stored at room temperature. So there's no need to refrigerate for these medication options. One last detail that I'll talk about, so the longer acting version of Invega Trinza, it uses a larger particle size than the Sustenna, so it does allow for that slower dissolution. And the Half-Yera actually extends that even longer. So it's the longest acting formulation that we have in this class, not just for the paliperidone, but in this class. Starting with the Azofri, the first dose was given intramuscularly on day 1. The nice thing about that product is that there isn't a required oral overlap for that. If you do oral overlap after the first injection, you should use extreme caution. After 4 weeks, you're going to give the next injection either in the deltoid or gluteal muscle and then continue every 4 weeks. Maintenance dosages can have a range. They can be from 39 to 234 milligrams, but you would adjust based on tolerability and efficacy. So it's nice to have that ability to go up or down in the dosages because the strengths, they do have 4 strengths that are available. They have the 39 milligram, 78 milligram, 150, 6, and 234. The Invega Sustenna is also a monthly option. Here you're going to start with the 234 milligram day 1. On day 8, it's the 156, but then after that, you can go to monthly. The second dose can actually be given anytime between days 4 and 12 if needed, and you don't have to orally overlap with this one as well. Dosages for your dosing window, because we all like dosing windows, it's real hard for patients to get there on the day doses are due. So they all usually do list a dosage window. So each dose can be given 3 to 5 weeks after the previous one, and adjustments can be made. But when you make adjustments, keep in mind with these products, can take a few weeks before you see the full effect. So if you change the dosage and you don't see it immediately, just hang on and wait. To talk more about the Trinza, so this is our 3-month formulation. This is for patients who've already been stabilized on the Sustenna. So you really wouldn't start this one as your first injectable. You want to be on the Sustenna for at least 4 doses, and your last 2 doses need to have been the same dose. So in other words, you want to make sure you're stabilized on the dose that's going to be your dose before you start the patient on this medication. The Invega Half-Yera, kind of same deal. You're going to have the same exact guidance. You either need to be on the Sustenna for 4 months. Again, last 2 doses need to be consistent. Or if you're taking a patient from the Trinza to the Half-Yera, you can do that as well. Switching to risperidone. So for the long-acting injectables, you have IM options and sub-Q options. So the IM formulations are risperidol consta and the Rykindo, and the sub-Q options are the Perseris or the Udezi. So all of these are indicated for schizophrenia, and then the IM formulation, the consta and the Rykindo, are also approved for bipolar disorder. Administration and dosing do vary upon which product that you're using and the indication. But there's a couple of key clinical pearls to keep in mind. So they do require oral overlap with the medication that they're currently taking. And then for storage, they do have to be refrigerated to maintain stability. So if that is a barrier, that's something to keep in mind. Delivery technology is a little bit different among the products. For the risperidone IM formulations, they're kind of like a beaded molecule and they slowly release over time. The sub-Qs they use a polymer solution instead of the beads and they get suspended in the solution. Once they get injected, they have kind of a depot that they form under the skin, and it gives it a little bit of an initial release followed by a sustained delivery. So some folks like that because this has a little bit more of a faster kick in than the other options. So before you start these meds, we need to show that the patient can tolerate the oral risperidone first. So for initial injection, you typically are going to start at 25 milligrams. If they're already stable on an oral dose, you can tailor the injection to match that. And they have dosage conversion charts that are pretty readily accessible in the package labeling. The maximum is 50 milligrams in a single starting dose, and you're going to initiate the maintenance dose 2 weeks after the initial IM dose. Key difference between the two comes down to the oral overlap. So with the risperidone consta, you have to keep them on the oral antipsychotic for 3 weeks after the first injection, which is a little bit of a significant overlap. With the Rikendo, it's shorter, so you just need 1 week. And then after that, the maintenance dosing is every 2 weeks, usually at the same dose as the first injection, but you do have the ability to adjust it up and down according to safety and tolerability and efficacy, of course. Now, it does take time for the changes once you're tweaking the dosage to be noticed. Usually, if you adjust a dose, it might not you might not see that change that you're looking for until 3 weeks or longer. So keep that in mind too if you're trying to get somebody to the right dosage. Switching from the Consta to the Rikendo, the patient would continue at the same dose. The first Rikendo shot that's given about 4 to 5 weeks after the last Consta injection. And for switching from Consta to Rikendo, you don't have to have any oral overlap. Looking at the sub-Q options, so we have Perseris and Udezi. So with Perseris, they also have to be on the oral first, but really there's a little bit of a catch with this product. They have to be stable between 3 and 4 milligrams of oral risperidone a day. If you think you're going to need to titrate them up above 4, this isn't an ideal product. And if they don't tolerate anything 3 or above, then it wouldn't be an ideal product for that patient as well. With Udezi, they do, again, still need to tolerate the oral risperidone, but the oral dose is stopped the day before you start the injection. So the maintenance dosing starts 1 to 2 months later after the initial dosing at the same dose as the first injection. So you do have some flexibility with the dosing, which is nice. It's a max dose of 125 milligrams monthly or 250 milligrams every 2 months. So in summary, you've got the Consta and the Rikendo as your IM options that need overlap. Perseris is good in sub-Q, but only if they have a narrow oral dosage range. And the Udezi sub-Q, no oral overlap and more flexible dosing intervals.
You have a question. It says, can patients give themselves the sub-Q injection first coming into clinic?
That's a good question. Let me check that right now. All right, sub-Q. It does not say in the package labeling, but anybody jump in.
I see for the Uzedy, it does say for healthcare professionals only.
Gotcha.
But not for sure about some of the others.
Yeah, the Perseris would be the only other option.
Is that you think just for control, or I mean, because there's a lot more places to give a sub-Q injection that you can give yourself. I mean, it's a little hard to give yourself a gluteal IM, and it's a much bigger needle, and it's harder to do. But I mean, sub-Q is pretty easy, and lots of people like for weight loss are giving themselves, and diabetes are giving themselves sub-Q injections. I just kind of wonder how portable this is, to
Yeah, I don't know why they
the
would
drug.
restrict it, because you're right. So, I mean, people are capable, certainly, of giving themselves a sub-Q injection. I mean, it does have to be refrigerated, but so do other things.
Well, and I think I love LAIs, but transportation is sometimes the
Mhm.
challenge to get there. And if you can give it to yourself and sort of bundle visits to the pharmacy with going to the provider, I mean it's a seems like a much more practical
I
thing.
agree.
I don't know. I was curious. I have zero experience with the sub Q ones personally. I gave lots of LAIs like the IM ones in clinics in the past, but I didn't know how, and I assume they're probably pretty still expensive and probably not the preferred agents on most insurance plans, which might be the other limiting factor. But I just wondered in practicality, like if what that might truly mean. That could be like quite revolutionary in many ways. If
Yeah, this says the Perseris has to be injected by a healthcare provider. It says just for better technique, but that's interesting. I would think people would be capable of doing it. And I can't, like I said, I have trouble with the Medicare coverage, but I can speak a little to the Medicaid coverage. I know some of these Risperdal products are covered. Let's see. Let me double check.
the sub Q ones too.
So the Ryakendo is, let me see about the sub-Q ones. Udesi's non-preferred for Medicaid for West Virginia. And Vega Hafira, Sustenna, and Trinza are preferred. Perseris, it says, is preferred, which is a sub-Q one. But it would be tough for them to come in every 2 weeks. So I get that. Let's see. The Hafira does require, the trials with the Sustenna, but that's kind of just consistent with package labeling. Same with Trinza. And then they do require prior auth, but they're preferred, but we just need the diagnosis for approval for those. That's a really good question. Yeah, you would think that it would be okay to have the patients inject those themselves. That would remove at least one barrier, especially in West Virginia, such a rural state where transportation can be hard. Okay. I think we're ready to shift to Abilify. So, okay, Abilify, we have several formulations. So the Aristada, and then the Maintena, and the Asymptophene. I always have to pause before I say that one. So the Asymptophene and the Maintena are also approved for bipolar disorder. All three are approved for schizophrenia. All given intramuscularly, and the dosing schedule varies based on which one you choose. Clinical pearls we'll talk about with these products. Just wanted to check my time. We look good. Clinical pearls, so there's oral overlap is required. Second, compared to some of the other atypical antipsychotics, one good thing about aripiprazole is that it does tend to have lower risk of metabolic side effects. When you think metabolic side effects, olanzapine's going to be a kind of a bigger offender, but aripiprazole is generally favorable for that. Especially in a state like West Virginia, where we have a good bit of obesity, high cholesterol, diabetes, that can be a major perk. But a drawback is that it does have a lot of CYP interactions. So we've got that CYP2D6 metabolism interaction. So it's going to interact with some medication. So it's not something that would preclude use, but it's something to be mindful of. In terms of how the drug is delivered, so the carrier salts dissolve slowly. They release the active drug. Aristat is a little bit different. The body's enzymes convert it into aripiprazole from the form that it comes in, the aripiprazole Loroxyl. As far as dosing, for Aristada, you've got some freedom of choice to tailor the regimen based on the individual patient. So package labeling supports either day 1 or day 21 of overlap with the oral aripiprazole. For maintenance dosing, there are conversion charts that are out there that they suggest intervals of every 4, 6, or 8 weeks. So you're not going to dose at 4, 6, and 8. You're going to pick one of those intervals to dose. But you can also give a maintenance dose as soon as 2 weeks after the previous dose based on tolerability and efficacy. So if you feel, pretty quickly that you need to adjust, you do have that flexibility. For the Maintena, before starting, the patients need to establish tolerability with the oral aripiprazole. It can take up to 2 weeks to fully assess this. So the Maintena is given once a month, but something to keep in mind with that one, you want to give it no sooner than every 26 days. And you do have some options for initial dosing that you can pick from. So you can pick from a single injection start or a double injection start. And the difference between those is going to be how much oral overlap you have to do with those two options. If you do the single injection start with the 400 milligram IM dose, you're going to do 14 days of the continued oral aripiprazole. Whereas if you do the double injection start, you're going to give 2 of the 400 milligram injections on the same day, and then you're going to do a single 20 milligram oral aripiprazole dose with that. And then you don't need any further overlap after that first dose. For maintenance, the standard is 400 every month, but if you have a patient that can't tolerate that, you do have the option to go down to 300 monthly. For the asymptoothy, it's like all the other products. You have to confirm the tolerability with the oral product first. There's 3 options for starting. So we see our familiar single injection, double injection option. Again, single injection, exact same guidance. You're going to do that 14 days of the oral aripiprazole. Double injection option is the same as with the other product, 1 single dose of the oral. Option 3 is if you've got a patient that you've got stable on the Maintena and you're wanting to switch them to the new product, you just give the 1 injection of the asymptoothy at the time the next Maintena dosage would have been due. For maintenance, the dose is every 2 months, but there is some flexibility there as well. So it's okay to go from anywhere from 6 to 10 weeks. Between injections, and if tolerability is an issue, you do have some options to reduce dosages to 720 milligrams every 2 months. So overall, the Maintena gives us a once-a-month option. The asymptoothy extends to every 2 months, but you have multiple ways of initiating the meds. So gives, again, the clinicians a little bit more options. Olanzapine, we have Zyprexa Relpreve, so just one product for the olanzapine. It's a long-acting injectable given as a gluteal intramuscular injection. Clinical pearls for this product, so it does require a 3-hour monitoring period after each injection because of the risk for a rare but serious reaction called post-injection delirium sedation syndrome, or PDSS. So I don't know if anybody's started this in a patient, but that sounds like a bit of a barrier to me, I would think, that the patient has to block off a kind of a significant portion of their day for that, and kind of frequently too. I mean, I guess it just depends. Second clinical pearl that we'll talk about is olanzapine has a high risk of metabolic side effects. So we sort of alluded to that before. So among the atypical antipsychotics, this is one that's a bit of a bigger offender. Things like weight gain, cholesterol, and insulin resistance are concerns that are associated with olanzapine. So on a positive note, you don't have to oral overlap with this one. So that's an advantage of this option. Compared to some of the other long-acting injectables like paliperidone, one advantage to the olanzapine that does give it a bit of an edge is that it releases a bit more quickly after injection, so it gives it a little bit more of an immediate effect. Zyprexa or olanzapine dosing.
Can I ask you a quick question about that one? At one point, I think you had to be like on the REMS registry to write that, and I didn't. Did that go away when like the clozapine registry went away, or am I misremembering that at all? Or There was some like you had to be like registered as a provider to get it or something. Like it was hard for providers, but I don't remember the details. And the clozapine registry went away, so I didn't know if that was still part of this or not. Do you
I
know?
know for sure the clozapine one did. For this one, I honestly don't know. Anybody know, or anybody want to jump in? It's not listed in the package insert. So, yeah, I'm not sure. Do you have any patients that you've started on that, Dr. Swagger? Like, because
Oh
that
no,
3 hour
that was
window.
always the barrier. So many patients were stabilized on Zyprexa as being closest to clozapine, and then they didn't convert them to the LAI because there was some barrier for the provider to get it. Like I don't remember what it was. I've never done it, but like there was something with like I thought it was like the REMS or something. But honestly, I hadn't, but and so many people never did this because of whatever that barrier was. But it hadn't even occurred to me that when the clozapine went away, I want to say it was REMS or something like I don't know. I may be completely misremembering this, but I think this was a huge barrier for providers to consider because there was something they had to do, and it wasn't just that 3 hour thing. I don't know. I I'm gonna have to figure out what I'm thinking about, but this is very interesting because if that barrier doesn't exist, I mean, even state hospitals weren't giving the long-acting Zyprexa because of whatever said barrier was, and I don't know what it was. But
Yeah,
if it's gone, that would be great because um, I don't remember what it was, but I thought I'd ask.
yeah.
I gotta go figure out what I'm remembering. It was like years ago.
I know Medicaid will often in their criteria say you have to at least attest you're enrolled in a REMS program if a drug has a REMS program, but not always, for sure. Like, I don't think they required it for clozapine when that program did exist.
Well, and that's why I wondered if maybe it went away when the clozapine one did or something, but I actually don't know the answer to that.
Yeah, interesting. I don't know. We'll have to find out. I'll do some digging and see if I can find anything. Yeah, that's a really good question though, but I would think that 3 hour window would be a barrier for patients and providers. All right, to talk about dosing. So the dose is based on the oral olanzapine dose that they're currently taking. The initial regimen is followed for about 8 weeks before transitioning to the maintenance. So unlike some of the other LAIs, there's not a need for the oral overlap. Once the first injection is given, the oral can be stopped. Maintenance phase, you begin dosing 2 to 4 weeks after completing that first 8 week series, but you do have to complete the first 8 week series first. So those are all the medications in a quick overview and the clinical pearls of them. So the biggest challenge, or at least one of the biggest challenges with these meds is access and cost, for sure. They're expensive. They often require prior auth. Insurance changes can be problematic. And even with insurance, sometimes copays can be extremely high on these medications. And then also the fact that they have to be, some of them administered in clinics can be a barrier for some patients. And like I said, particularly in a rural state, that can be a barrier for some people. There are manufacturer samples and patient assistance programs that can help bridge that gap. I couldn't find a ton on that, and I even reached out to my contact at Allied because they do a lot of reaching out for patient assistance programs for things like Hep C meds, and she said they just don't really get into that a lot with this class of medications. She said it just doesn't really come up that much. And she also said they only have one Medicare patient that's on a long-acting injectable. I mean, probably due to coverage, but she didn't say why. But I couldn't find a ton on that, but I'm sure that there are some patient assistant programs out there. Another burden that we can talk about is patient acceptance and stigma. So because it's a mental health diagnosis, some patients feel like they don't want to be labeled as a schizophrenic patient or a bipolar patient, and be labeled as carrying around medication for that. They might also associate injections with more severe illness or even institutionalization. So the way that patients are counseled can be important, and the way that providers frame the medication and the medication option can really matter. So we can, kind of frame it as, this is for your convenience, this is to help you with adherence, so that you don't have to think about your medication every day, rather than, a loss of control, like, we don't trust you to take your medication every day, so you're coming in to get a monthly injection. So if we can, work together with the patient on a treatment option that works the best for the clinician and the patient, that's really the goal. Side effects can also feel like a big issue with the long actings, because with an injectable, they're obviously going to last a bit longer than if an oral medication is stopped. It's in the system less long than if an injectable medication. So that can be a scary thing too, and maybe give clinicians pause on starting these medications. A survey of the physicians' attitudes towards the use of long actings was interesting to me. They found that 50% had decreased their use of long-acting injectable atypical antipsychotics over the past 5 years. And that was despite acknowledging that there is better adherence with those types of medications. So there's definitely some barriers. And, it's also, it's a survey of physicians' attitudes, but maybe they just feel like it's just too hard to get them covered, so why prescribe them? It doesn't source into what the reason for the attitude change was. So I think these barriers are all just really relevant.
So you have a question. It says, can these be administered same day as MAT?
As same day as what?
MAT, MAT.
Oh, MAT. They can, yeah. I mean, it's always, I'll give like the standard answer for any question of that nature. So it's always not great to start two medications that your patient has never ever been on at the same time. But other than that, it can be started at the same time. That's a really good question.
And real quick, Jenna had put in the chat that it looks like the REMS for the Zyprexa is still active due to the 3-hour observation window.
Interesting. Makes sense. Is it hard to sign up for the REMS program? I've obviously never had to do it.
Well, I've not signed up for it for this one. I mean, when you signed up for clozapine, you had to like read a bunch of stuff and take a little test. I mean, it's like another hoop to jump through. I mean, so it's not particularly convenient. So I imagine there's still something you got. I mean, I don't know I don't know if anybody on here even would know. I just think I mean, that's why they got rid of it for clozapine. It's just a barrier for providers. I'd be very curious to see how many people have ever done it for this one. I would not. I would be very surprised if there was anyone, to be honest. It's when there's so many other options, and I've never seen anyone write for this, to be honest. We always learn about it, but
yeah, you probably want to be prescribing it for more than just one patient too, if you're going to go through all that for it too. So yeah, I can understand that for sure. I have some stats on this slide and the following one. I'll put them up there for everyone's viewing pleasure. But I know you all had asked about Medicare coverage, and like I said, I don't have like the best info because it's really not out there. So I had Allie, my student, do some legwork on it, and really where we got this info was on the Medicare site, and we just would kind of plug and chug for some options. So these are prices for if you select that they're using a mail order in-network pharmacy with no monthly premium. And then there were some meds, and don't take this as this is perfect and correct. This is just what we found. We couldn't find coverage for Haldol. And we also couldn't find coverage for Invega Trinza. Not to say it doesn't exist, but we couldn't find it, kind of trying to do a little bit of a deep dive. But we looked at Medicare Advantage Plan Part C's and Part D's. And as you can see, the cost of these meds is significant, particularly if your insurance does not cover it, and sometimes even when it does. But I'm sorry I don't have better answers for you all on that. Anybody have any questions?
I'll just add that's like super cheap compared to the price of a hospital stay, though.
Yeah.
For
Yeah,
many.
but for the patient to pay out of pocket too, that'd be tough.
Yeah, I know, but I said it really comes down to, you know, what is the cost, because from a clinical perspective, these medicines are really quite effective, both financially and to improve people's health. It's always sort of surprising to me sometimes that, you know, who makes a decision financially about stuff, but
yeah,
but
outcomes
but it's
are
also very
important.
massively different. I mean, that's the other, those are pretty wide swings on cost too.
Yep. Well, these ones that are starred are just not covered, so those are kind of cash
Are there
prices.
any head-to-heads on any of these, like comparing LAIs, like were they? I mean, I know they probably had to be compared to some standard for treatment of the illness, but I wonder, is there ever any data like of comparing the efficacy of one LAI to the other,
Yeah,
or
not
like
that
which one's better, like that you've ever seen?
Yeah, not that I've seen that there's just one like this is the best med study. Not again, not to say that it's not out there, but I think it's just based on, your patient's profile. So I mean, like I said, if they've got, some weight issues or maybe already have diabetes or are battling high cholesterol, I'd probably stay away from the olanzapine products. Abilify is pretty well tolerated and patients do pretty well on it. Prolactinemia can be an issue with the paliperidone and the risperidone, but I mean, I don't know about the adult population that's super significant. Things to consider. I think a lot of times when you're at the point of long acting, they've tried some oral stuff. So you have a little bit of a basis of what they did well on, what they didn't do well on, and I guess kind of go from there.
And I wanted to ask you this, and I have no idea what the answer is, but there's been more and more studies coming out in child and adolescent psychiatry about the use of LAIs in pediatrics. I don't think any of them have been approved for that purpose, but we are starting to see more and more of that being a consideration. I obviously have no idea what that means in terms of approvals, but I wondered if you had any. Am I missing any indications for pediatrics that have come out that maybe I didn't know? But are you starting to see any requests for pediatric LAIs, or
I
do you
am
anticipate
not.
that being on the horizon? I said we had about 4 kids the last few months. They're all out of state that will probably be coming back, but on LAIs. And again, the data coming out in the literature on child analysis is showing it actually being really good good for that population, and they really like it, not having to take a medicine every day too. That it's showing a lot of benefit in our literature. I just didn't know if you had any updates on any of that coming, or thoughts about
I
that.
don't. It would be great though. And I will say when I help the staff with the queue and do requests myself, I'm mostly pulling atypical antipsychotics for kids. And I've not seen any that I've pulled that have been for injectables. But generally, if they don't have the indication, they're a pretty hard no on it. Not that you can't appeal, but yeah. Hopefully coming down the road someday, because that would be great. Well, thanks, guys.
Thank you. Do we have any more questions from anyone? All right, it doesn't seem so. So to wrap up, our next session will be October 1st, and we will have treatment of functional neurological disorders by Dr. Nick Jasinski. So we will see everybody then. Thank you so much for our presentation today, Angela.
Thanks all. Have a good day.